Hello, everyone. Welcome to our USMLE Step Prep series. I am Dr. Nizamani, and we have with us
Dr. Hanan.
welcome, Dr. Hanan.
Thank
So today we're going to talk about a very, very interesting topic. We'll go ahead and share the question and then see what you guys think. At the same time, we're going to discuss the diagnostics of it, the etiology of it, and the treatment of it. It's a very interesting question because this is a topic that we often see in the board questions, in practice exams, in USMLE style questions. So whether it's whatever Q bank you use, you're definitely going to come across this disease. And it's a genetic disorder. So when you're going through the questions, it's something that you can keep in your mind. And I love the slide.
Yeah, if you don't have chromosomes, you can get genetic disorders.
Very true. But you're not human.
I don't think what you might be inorganic. So
yeah, true.
This is an AI special.
Oh gosh.
All right, so let's jump right into the question and we'll go from there and see how we address it. So I'll read through the question. It's a 6-year-old boy who's brought to the clinic for a follow-up appointment. The patient is in a remedial program at school due to his delay in academic progress. On multiple occasions, the patient has bit his fingers and lips. He has a 9-year-old brother that has no developmental delay. The patient was delivered at 40 weeks as a spontaneous vaginal delivery with no complications. Which of the following is the most likely cause of this patient's presentation? So right off the back, a lot of interesting things that are being provided to us, right?
So what are some of the important pointers that you would focus on when you're addressing this question, Dr. Hanan?
Some of the things I would point towards would be the delayed academic progress, right? Definitely trying to see as to why this child might have some cognitive impairments. Biting his fingers and lips also provides me a little bit of a clue with a little bit of self-mutilation. So those two areas can provide me with some idea of where I should be looking at and where I should be going. And so the question that they're trying to ask for is what is the most likely? Now, a lot of different conditions do cause cognitive delay in children, unfortunately. And so we have to figure out what is the most likely cause in this one, not what is a cause. So the fact that he is biting his fingers and lips, he is a boy, those are some clues that I would say are big ones. His 9-year-old brothers, they spoke about it. Why would they talk about a brother or a sibling? More often than not, whenever they want to talk about a sibling or a paternal uncle, maternal uncle, they're trying to get you to think about an X-linked problem, right? And in this case, the fact that the brother, it's perfectly okay. I'm assuming that whatever the problem is, it's definitely not an X-linked dominant disorder. If that was the case, then both boys would definitely showcase the problem. So just off of that information, I know that whatever this is causes cognitive delay, causes self-mutilation, part of the disease, part of the pathology, and it is an X-linked recessive problem. Now, although I could rule out chromosome X related, but for this time's sake, I'm going to rule it in for now. And if anything further, we'll try, but more at the moment, I'm thinking that's the way to go.
So from what I'm hearing from you, some of the things that I think you're mentioning that are kind of like the key factors would be kind of like the biting his fingers and lips, like the self-mutilating aspect. And then also where they're giving us hints on the possibility of the inheritance pattern or what we can rule out. Even if we can't rule something in, we can rule some things out. Right. So, and then when you would go ahead and maybe read the answers, how would you, what are some things or some answers that you feel like you could just right off the bat rule out based on what you already know?
Well, right off the bat, I could rule out something like autosomal trisomy, right? Because I don't think this, whenever they talk about perhaps, let's say, Down syndrome or the Edwards, they're often, they're often talking about some specific characteristics and facial characteristics they often point out. Anatomical characteristics are very key whenever they speak about any of the 3 trisomies, which is not really discussed here. So I will just rule that out. The trinucleotide repeat in FMR1 gene, this could be a very, very close differential
Right.
to the actual diagnosis. It's also linked to an X-linked, right? It's also showcases cognitive delay and other aspects. But I'm gonna keep it in, but we'll come back to it, and then I will rule out the adenosine deaminase deficiency because at the moment I don't think it looks like he's got any immunodeficiency problems, so I can just rule that out. I don't think they have not talked about any infections that the child has. And nowhere near that area, so I can just rule those out. So it leaves me with B and C. And so what I'm going to do with B and C is because I know that out of these two, self-mutilation is a big thing for something called Lesch-Nyhan syndrome. I'm going to go ahead and pick the B, which is the with HGPTD deficiency. I know it's a very long word. So
it is a very long one. Yes.
That's the one I'm pointing towards, and that's why I would just rule out C. Now there are other ways you could rule out C too, right? You can think of the trinucleotide repeats and what they stand for, giant gonads and all that. But we don't have to get to that. I can just rule in based off of the biting fingers and lips. B is the correct answer.
Awesome.
Right. So exactly. So as I was saying that I'm pointing towards that it is Lesch-Nyhan syndrome, which is an X-linked recessive disorder and the deficiency of this very particular enzyme in our purine salvage pathway, which is very important in terms of our proteins that are being salvaged to be able to create these, these products for us to develop all sorts of different proteins, so allow us to be able to build
synthesis.
Exactly. We need these, right? Purines for so it's very important for that aspect. And if let's say there's an hindrance, and we obviously see a lot of defect in terms of cognitive impairments and other aspects. So one thing that is very, very, very key about this syndrome in particular is the self-mutilation, and it's because of a compulsive disorder. It's some sort of it's a compulsion for them to do it. They're not doing this because they want to. They're not doing this because of some sort of a pain receptor. They actually, in comparison to normal individuals, their pain symptoms and neuronal senses are all the same. The thing is that they have this compulsion to continuously either bite themselves, right, bite their lips, get rid of, fidget through the bones and fingers.
Right.
And they often can take away skin and go all the way to the bone, unfortunately. And so they also have other problems such as chorioathosis, which just means choreo dance, athosis, finger movements or limb movements. You often see these children with their hands, in certain motions, but like snake-like movements. And so these are some of the disorders that are very, some of the symptoms that are very common, right? And what we have to focus on is the uric stones, the uric acid stones that start to build up in the kidneys that can cause kidney damage, and also the gouty arthritis, them start to being trapped in the joints and causing pain and arthritis and deterioration of those joints. All right.
Awesome. So then how would you diagnose Lesch-Nyhan syndrome? You have a patient, a 6-year-old, just like this boy, comes up and he has all these classic symptoms, right? He has, self-mutilation behavior. He has decreased cognitive development. So you know that the academic performance isn't as it would be for a child that age, and maybe they're presenting with renal stones or they have gouty symptoms. How would you go about, what would be maybe the first test that you would do in that case?
So whenever it comes to genetics, it's often very difficult for sometimes a primary care doctor to go ahead and start diagnosing. So more often than not, you have to kind of look at the clues, look at the things that are often presented in the clinical settings, and then try to get your diagnosis or try to get a differentials. And then they will be needing further genetic testing in order to prove out that diagnosis. So you can do the HPRT gene analysis, which will provide the evidence that it is the deficient. You can also look at uric acid levels. Within the serum, there will be extremely elevated. There will also be the 24 urinary acid excretion. You will see elevation in uric acid. And so one very common thing is that you see orange sand crystals in the diapers of these young babies.
Right.
So these are some signs and clues that the doctors can look at. But in order to confirm the diagnosis, you will have to do a gene analysis.
Right. Awesome. And I think one of the things also to keep in mind as we go through the diagnostic aspect of it, in terms of the board style questions, is that they can manipulate the question to ask or maybe share this information in a certain way. So that could be a key factor, right, in determining the right answer. So maybe they would go ahead and they'll actually say that, their HGPRT is deficient, and they go ahead and tell us the diagnosis. Or they'd be like, in Lesch-Nyhan syndrome, which levels would be elevated? And then that's uric acid levels. Or they'd go ahead and be like, this patient presents with, so obviously a patient wearing diapers is someone who's younger. So if they're talking about like a 2 or 3-year-old and like the patient is constantly biting their hands and lips, and also has these sand crystals in the diaper, what's the diagnosis? So that could be Lesch-Nyhan. So anytime, I think, whenever you're reviewing a question and maybe you have more to add to it, think about the ways that they can ask the question in terms of the boards, because you'll see these the pattern constantly.
Yes, exactly. And that's actually a fantastic way to learn and study, is how can a certain question be actually asked. And once you kind of get the idea of how a question is asked, it becomes quite simple to answer it because you already know it. You're working backwards.
Exactly.
You know the answers, you know all of the diagnosis, you know the disease pathology. Now you're saying, well, what are they going to do to ask? How will they ask?
Right. And it's just like knowing that these are not just 5 random facts. It's actually a whole concept about a disease. So you don't need to memorize, you just need to understand. Once you do, then as you're presented with the question, you'll be like, oh, this is a whole concept. Now I can pick up the keywords and choose the right answer.
So the treatment options are, you have to mitigate the uric acid levels that have increased. So allopurinol and febuxostat are the 2 main ways to kind of stop them from producing more uric acid, because at the end of the day, unfortunately, we don't have a way to get rid of provide the enzyme for the deficiency. But what we can do is mitigate the consequences of that deficiency. And so if the uric acid is elevated, fight towards decreasing uric acid. And allopurinol and febuxostat do a fantastic job. They kind of attack the xanthine oxidate enzyme and then stop the production of uric acid. Now, as for the neurological problems, unfortunately, there are behavioral modifications therapy. That's the only way to go about it. One-on-one interactions with these patients to get them to understand the situation that they're in, and to the best of their abilities to help them mitigate the neurological difficulties that they must be going through. And benzos and gabapentin can also be beneficial in these cases, and sometimes they use neuroleptics, but it's often discouraged to use them for long term because, again, they're not antipsychotic. The situations are that, unfortunately, they have these muscle dystonia, spasticity, which require a little bit of behavioral guidance and therapy, where they can discuss with them what to do in a situation if you have like dystonic movements.
So what are your thoughts on the idea of, like, a patient comes to you or a physician comes to you as like, Dr. Hanan, what's the cure? What would you say to them?
Well, that is a tough question, because if they, unfortunately, there is no cure for the disease, for the pathology and the syndrome. The best we can do is try to make their life better. And in that situation, our goal is to bring down the symptoms to the best as possible. So if they're having dystonic symptoms, then we try to look at some Parkinsonian medications, try to alleviate those spastic movements, and then try some other alternatives within the same bracket of neuroleptics as well, which kind of can cause extrapyramidal symptoms as well. So it's basically a balance and trying to mitigate the symptoms. And if an individual asks the question, well, can I get better? We can always provide support, and that's the whole goal of medicine sometimes. Unfortunately,
symptom control,
exactly, symptom control, and being able to just be there for a patient is sometimes what you need to do, rather than being able to cure certain uncurable diseases or uncurable problems. Sometimes all they need is a little bit of human interaction.
And I think just also it's important to know that, like, maybe share the idea that, hey, it's a genetic disease, right? It's not something that it's not an infection. It's not something bacterial or viral. This is something that's kind of within your the makeup of your genes, unfortunately. And so it cannot be cured, but as Dr. Hanan mentioned, we can make you comfortable and we can do the best in that case. So it's not the best case scenario, but sometimes that's kind of the reality of.
And often more like, the prognosis being poor, being that it's usually the kidneys that get affected the most, and that's usually what leads to the demise of the patients, unfortunately.
Absolutely. And then here we also have a purine salvage deficiencies pathway.
Which is a fantastic review for many of the students to take a look at this pathway. Step one likes to get into the nitty gritty, and although me personally, I have not seen these in a long time. But I know how important they are for biochemistry, how important it can be for step one.
I think it's a good visual. I know a lot of people don't like it. It can seem complicated, but actually it's a great visual from first aid of 2022. I think it's page 35. I could be wrong, but what it really shows us what the function of HDPRT is, how it works, what is it trying to salvage. So it's trying to basically bring back guanine, or trying to bring back hypoxanthine, right? And instead of our body having to continuously make
new
these So and that's really the salvage pathway deficiency, because you're trying to salvage these bases, which you're unable to do because of lack of this enzyme. Right. So it's a great image because it also helps differentiate between the ADA deficiency, which is one of the cancer options, right? Adenosine deaminase. And then you can also see the workings of allopurinol and febuxostat. And so I feel like it's a good visual, but it can be confusing for some people.
Of course.
So it's there if you'd like to review it.
Oh, I think our computer just froze.
Oh.
There we go.
There we go.
Okay.
Okay, excellent.
So we're back.
I think we had one from the last recording. I already have papers.
Oh, nice.
So we actually kind of skipped this photo because I think the computer froze. It took us to the last slide.
I think it took us straight to the last slide. So again, let's just reiterate really quickly. Leishman syndrome is a defect in the AGPRT enzyme in the salvage pathway. And as Dr. Karen was mentioning, that it is a salvage pathway for your DNA synthesis backbone main ingredients. And so what they do is whenever you're deficient in one area, the cycle goes to the other side, wherever they're basically like floodgates. If you close off one area, they'd go over to the other, and so they start to produce a lot of uric acid, and that causes a lot of problems, which is hyperuricemia, elevated of uric acid, gout when it starts to deposit into your joints, and then pissed off, that just the aggression and the self-mutilation, unfortunately, that these individuals have, the red orange crystals within the urine, and the tense muscles, the dystonia from their muscle, unfortunately, muscle problems that they have. So treatment, again, mentioned allopurinol, febuxostat, so that's just basically review from the first aid that is sitting there. The pages are mentioned for the individuals to look into. And again, the cycle further shown in a bigger, easier image, I guess.
But here you have it. So thank you so much, Dr. Hanan, for going through Leishman syndrome with us and explaining to us kind of the nitty-gritty details, what to look for, what not to look for. And as always, our students and other individuals can definitely reach out to us, follow our YouTube page, and regularly on a weekly basis, we'll discuss questions here. Feel free to hit that like and subscribe button.
Yes. Awesome. All right. Take care, guys.
Bye.
Bye-bye.